there is still some indecision as to optimal therapy in patients who have multiple conditions. So I wanted to focus on a paper from the Journal of the American College of Cardiology. This JACC paper is oral anticoagulation and antiplatelets in atrial fibrillation patients after myocardial infarction and coronary interventions. And what I would really like to do is introduce you to Dr. Morten Lambert's Copenhagen University Hospital, Gentofte in Hellerup, Denmark. A great paper, congratulations, number one. A Young Investigator Award nominee here, congratulations. Can we talk a little bit about why Denmark was a great place to do this particular study?
Yes, thank you very much for your nice words. It was feasible to do this kind of study in Denmark because we have the possibility to cross-linkage nationwide registries. So information on prescription data, very detailed prescription, detailed information on admission, and so on. So we have the possibility of a research design that made this comparison of treatments possible.
So how many patients in this particular analysis?
In the total population, I included 12,000 patients, and then in some of the treatment regimens, it was of course a smaller number.
So why did you look at this particular issue?
I find it very interesting to look at a particular subset of patient, and that was a patient that had both atrial fibrillation and coronary artery disease, because we didn't know very much about how to treat these patients, because they both have an indication for antithrombotic therapy, and we don't know if it's rightful just to mix these two together.
Now, you did a piece in Circulation, I believe, like a year or so ago on triple therapy. So 3, 2, 1. Do we have a countdown to clarity here?
It depends on where you are on the degree of coronary artery disease. So if you say we have atrial fibrillation patients which have one indication for antithrombotic therapy, it might be different what kind of combination you want to these patients, either if they have an acute coronary infarction or if they have stable coronary artery disease.
And PCI.
And PCI, yeah. So it depends on which spectrum, how many drugs we might want to give these patients.
So what clinical lesson comes away from this particular paper?
From the JACC paper, our main conclusion were that we had no reasons to believe that a regimen of vitamin K antagonist plus clopidogrel, but without aspirin, was as good as triple therapy, which is currently recommended concerning thrombosis risk. And we saw a tendency towards a decreased risk of bleeding with the 2 drugs instead of 3 drugs.
And does that kind of jive with what you were talking about in the Circulation paper a year ago in terms of triple therapy?
We had very detailed information in that paper on particular bleeding risk, and that was the initial bleeding risk. Physicians have long thought that if you prolong treatment with combination therapies, your risk of bleeding increases. But what we showed in the Circulation paper was that this increase in bleeding combination therapies was evident right after initiation of therapy. So there was no safe therapeutic window, especially for triple therapy.
Well, for JACC, please make sure you look up Dr. Lambert's paper, and it is a very good one. We also have other Young Investigator Award nominees that we're talking to at this meeting, so please make sure you get a chance to read CardioSource WorldNews and our coverage of the European Society of Cardiology meeting. I'm Executive Editor Rick McGuire.